Today we're revising occipital condyle fractures, a high-yield but often missed injury at the craniocervical junction. This injury requires a high index of clinical suspicion, especially in the setting of blunt polytrauma. Understanding the anatomy of the craniocervical junction is crucial. The occipital condyles articulate with the atlas to form the atlanto-occipital joint. These structures are stabilized by the LR ligaments and the tectorial membrane, providing critical stability to the base of the skull. Definitionally, these are fractures of the occipital condyles where the skull meets the first cervical vertebra, C1. Important exam point: CT scan is the diagnostic tool of choice. Plain X-rays are notoriously unreliable here. Because of their location, these injuries are frequently overlooked in initial radiographic screenings. Always maintain clinical suspicion in patients with high-energy trauma and persistent upper neck pain. Epidemiologically, these are rare injuries accounting for approximately 1 to 3% of blunt craniocervical trauma cases. However, they are being increasingly detected due to the routine use of CT scans in trauma centers globally. It is critical to remember that they are frequently missed on plain radiographs, which can lead to delayed diagnosis. While rare, the potential for neurological catastrophe makes early identification vital. The mechanism of injury typically involves high-energy trauma, most commonly motor vehicle collisions. Falls from significant heights also result in high-energy axial loading, transmitting force directly through the spine. In elderly patients, even low-energy ground-level falls can cause these fractures if significant osteoporosis is present. The key forces involved are rotation and axial compression, which can lead to unstable fracture patterns. Associated injuries are very important for exams. Spinal cord injury is seen in roughly 30% of cases. Vertebral artery injury is a major concern due to the artery's close proximity to the condyle. Cranial nerve palsies involving nerves 9 through 12 are key clinical clues you must look for. In severe cases, brainstem injury can occur, affecting vital functions like breathing and heart rate. Because of the vascular proximity, you must always suspect and rule out vertebral artery dissection. Early recognition and immediate management are essential to prevent secondary neurological damage. The Anderson and Montesano classification system is the most commonly used framework for these fractures. Type I is an impaction fracture caused by axial loading. These are generally considered stable injuries. Radiologically, you'll see the condyle crushed or impacted, but with minimal displacement of the bone. Type 2 involves a skull base extension, usually occurring as part of a basilar skull fracture. These are also stable. In type 2, the alar ligaments are typically preserved, maintaining the stability of the craniocervical junction. Type 3 is an avulsion injury. This is the dangerous one you must remember for your exams. Rotational forces pull the alar ligament, which in turn pulls off a bone fragment, creating instability risk. Exam Pearl. While type 1 and 2 are stable, type 3 represents a significant risk of craniocervical instability. Clinically, patients often present with significant upper neck pain following the traumatic event. Neck stiffness and restricted range of motion are common findings that should raise your suspicion. An occipital headache or tenderness at the base of the skull is another classic presenting feature. Crucially, look for deficits in cranial nerves 9 through 12, which can indicate local compression. On examination, a restricted cervical range of motion is expected, but manipulation must be done with extreme care. Avoid excessive manipulation until instability has been ruled out. A full neurological assessment is mandatory. Moving to imaging, the CT scan remains the gold standard for diagnosing bony fractures in this region. MRI is essential for evaluating ligamentous integrity and identifying potential spinal cord injury. CTA, or CT angiography, is used specifically to assess for vertebral artery injury or dissection. I will repeat this as it's a favorite exam question. Plain X-rays are often completely normal. Use CT for the bone, MRI for the ligaments, and CTA for the vascular structures. Never rely on a clear X-ray to rule out an occipital condyle fracture in a trauma patient. Management is primarily non-operative for stable fractures, such as Anderson and Montesano types 1 and 2. Treatment typically involves immobilization in a rigid cervical collar for a period of approximately 6 weeks. Consistent immobilization allows the fracture to heal while maintaining craniocervical alignment. Surgical intervention is indicated for unstable type 3 injuries or where there is evidence of instability. Other indications include neurological compression or persistent craniocervical instability on follow-up. The standard surgical procedure is an occipital cervical fusion to stabilize the junction. This involves rigid fixation spanning from the occiput down to the C2 or C3 vertebrae. Bone grafting is used during the procedure to promote biological fusion and ensure long-term stability. Complications can be significant. Vertebral artery injury is a major perioperative and traumatic risk. Venous sinus injury is another potential complication during surgical approaches to the occiput. Long-term, patients may suffer from chronic neck pain and stiffness, regardless of the treatment modality. Following fusion, adjacent segment degeneration can occur over time as forces shift to the lower cervical spine. Let's wrap up with the exam pearls. First, the CT scan is your definitive diagnostic tool. Second, remember that plain X-rays are commonly normal and should not be used to exclude this injury. Third, lower cranial nerve palsies, nerves 9 through 12, are critical clinical clues. And fourth, type 3 avulsion fractures carry a high risk of craniocervical instability. Internalize these 4 points as they are high yield for both written exams and clinical viva. Early identification and correct classification are the keys to successful patient outcomes. That's our high-yield revision of occipital condyle fractures. We've covered anatomy, classification, and treatment. Use these key points to guide your study for exams, clinical rotations, and medical MCQs. Keep practicing your anatomical reviews and clinical imaging assessments to master these high-yield topics. I'm Dr. Welly. Thank you for watching, and I'll see you in the next high-yield revision session.